Good afternoon, and welcome to Innovacers Driving Performance and Unlocking the Full Potential of Risk Adjustment Across the Care Continuum. I'm Michelle Zillish. I'll be your moderator today, and very excited to have us joining us today is Dr. David Nace, Chief Medical Officer here at Innovacer. I'll let him introduce himself, and then we'll have also Malika from MCHC Health Centers also introduce herself and tell a little bit about what each of them are doing at their organizations before we get into our agenda today. Dr.
Thanks,
Nace?
Michelle. Yeah, absolutely. Thank you. And David Nace, I'm a physician trained in family medicine, primary care. Spent most of my early career at the University of Pittsburgh Medical Center in Pennsylvania, where we built what is now the second largest integrated health system by building a payer and doing an integrated delivery system over the years, second largest in the country to Kaiser Permanente. And then subsequently, I've worked for on the payer side, helping to build a company they now know as Optum, and then working for McKesson, providing technology for a decade to payers, and more recently with a data company, Innovacer. And we'll talk a little bit about what we do as we get into the questions.
Thank you, Michelle, for the introduction, and thanks, Innovacer, for having me on this webinar today. Malika Madhukasara, I'm the Director of Population Health at MCHC. We are a federally qualified health center in Northern California, beautiful wine country. And we have 4 clinics and around 30,000 patients. We offer primary care and a number of specialties, including behavioral health, dental, pediatrics, OBGYN, SUD and MAT, as well as some other specialty services. I manage a fairly large department, and under me are a team of teams. I have IT or IS, I have clinical applications, I have analytics, I have 2 community health teams, as well as 1 QI or care coordination team. So my title is a little bit deceptive when you think about scope of responsibility. I've been in healthcare for 15 plus years and counting, and my healthcare career started with payer. I worked for Blue Shield of California for a number of years. Before moving on to health tech, I worked at Oracle and helped establish their healthcare industry practice before coming here at MCHC, and I've been with them for the last 2 years. And so I'm looking forward to sharing my insights and takeaways from some of my experiences and observations on challenges, as well as how we've used technology here.
Perfect. Well, I look forward to the conversation today and appreciate both of you doing your quick, brief introductions. As we look at it for our agenda today, we're going to go through our panel discussion. Then we'll take some Q&A from the audience. You will see that the chat box is available for you to connect and put in questions. You can put general questions in or directed questions for our participants, and we'll be happy to share those with the team and let them answer those questions for you directly. And then we'll have just some key takeaways here at the end, as well as then a survey for you to complete with regards to your opinions on today's webinars. So moving in to our next slide real quick, let's talk about some of the things that we're seeing as challenges with underserved populations. And one of the things that we're seeing with numerous things with regards to SDOH, how are you seeing those impacting your patient populations and engaging the different providers to help support your membership?
Yeah, I think it's a great starting point to address, especially in healthcare. For MCHC, given our mission as well as being an FQHC in an underserved or rural healthcare desert, we cater to a very high proportion of low-income or Medicaid or Medi-Cal population. Of over 52% of our patient population are Medi-Cal patients. And a lot of our patients in the community have a lot of gaps and issues. I call them structural issues: housing, transportation, healthy food. Some of them don't have Social Security, so they need help with filling out forms. And so there are a number of things. And it's been our belief right from the get-go, and it's embedded in our mission that we need to be able to address these structural issues and social needs gaps systematically so as to be able to close gaps in healthcare as well as offer well care and sick care. And so, given that, I have two community health teams who are grant funded, and both these teams approach our community through different channels. When I say channels, it's really referral pathways. Some of these referral pathways we've created internally where our providers, as they see patients, are able to refer to the community health team when they encounter patients having any kind of issues, whether it's housing, transportation, domestic abuse, those kinds of things. And so the community health team then does the outreach, and depending on what their top two priority areas are, they will set them up with either enhanced care management program, or in some cases, just offering them help in the areas that they need. And we really work hard to with the patient and help them achieve their goals. So it's a very goal-oriented program. And ultimately, if you don't have a roof on your head and if you don't have access to food, it's really hard to get a colonoscopy, or you can't come to the office. So that's how we've been addressing socio-determinants of health gaps.
Those are great comments. And, as a physician who have looked at this area about how do we improve the health of a population for much of my career, what we've learned over decades, some 20 to 25 studies have looked at this, is what are the actual drivers of improvement in health and health outcomes. And what we find is that about 40% of the outcome is due to what are social, environmental, and economic issues. What you just referred to as the social determinants of care. And it sounds like your community health teams are doing a great job of helping to reach out to those that you identify as having needs and then fill that gap. Another 30% is actually driven by individual patient behavior, meaning just like all of us, we're all different. We respond to different things, different ways, incentives. We have a different level of education, so that drives our behavior, but it's a behavioral. How do we behave in response to things? Some people are good at going to the gym all the time, and some people only go in January for a week, and some people never go. So behavior is a big driver. Do you take your medicines? Do you exercise? Do you frequent the doctor? And the chagrining part is, and there's about a 7% that comes in that drives from genetic reasons, things that we're born with, but it's only about 15% of the outcome is due to medical intervention. Now, part of that's due to the fact that we haven't done a lot of preventative care because it's not necessarily paid for in a robust way. But the actual medical care that we deliver is really a minor contributor to health outcomes. So as we think about population health, it's just an important thing. And that's why, Malika, the work that you just described at the Community Health Center, it's just awesome, because that really starts to tackle the real problem.
Yeah, absolutely.
What do you see as the current biggest challenge right now for your community health group as they're reaching out? Is it lack of resources, funding, or is it even technology based?
Yeah, so for us, we have what I call a supply and demand gap because of where we are. We tend to be pretty much the only primary care provider, and oftentimes it's hard for us to make availability for patients to get in a timely fashion. So typically, we are always in a situation where we have a limited number of appointments for more number of patients that are needing care and wanting to see us. So that's access is a huge issue. The second thing is we have a couple of our clinics in rather remote locations, and geographically in one location we have this huge lake, and that tends to be very isolating, and oftentimes in that particular area or county we have a lot of gaps and issues with transportation. And our managed care Medi-Cal payer does offer transportation services, but it's not always reliable. And so we often have to supplement that gap with offering transportation services ourselves. And some of it, we do it through grant programs and others. I think the third area is just getting people to, when we do outreach, to follow through with their preventative care screening. So I have a team of folks who do outreach. We get a roster of patients from our payer, and we know exactly, who to do the outreach to when it comes to closing care gaps. And obviously, there's a lot of analytics and scrubbing involved to make sure we don't have interoperability gaps and the data that we have in the EHR is accurate. So there is obviously a data gap and a technology piece to it. But beyond that, just to get people in the clinic is sometimes challenging. And some of these challenges are also due to the fact that, it's hard for some of our patients to just take time away from their regular job because they don't get paid. And it's hard to accommodate everyone after school hours, right? You only have limited number of slots. And so the way we have tried to address some of those gaps is for our community health team and that particular program, we offer street medicine. So we actually go out to these shelters and we are able to, one of our providers, we go there. There's a place called Building Bridges in Ukiah, and every Monday, one of my community health teams goes with the provider, and so the provider is essentially providing care, and this team essentially accompanies that provider and helps that set of patients with, filling out forms and addressing any other issues they have. So we have tried to get out of this construct of just being in the clinic and getting out to people where they're at and meeting them where they're at. And beyond that, we do have aspirations and plans to get more remote monitoring. But then again, we have some connectivity issues. Not a lot of our patients have the best internet access and those kinds of things. So those are just some technological barriers as well that we have to overcome.
Malik, I really like what you started out saying about, and there was so much to unpack on what you described, is this issue of just simply scheduling. And we can walk through a myriad of things that you got into because we could spend hours on this. But I think you mentioned gaps. So there's people talking about gaps in care. What's the care plan? Is there something that's not being addressed? Gaps in quality. Is there a quality measure like a STARS or a HEDIS? And we talk about risk adjustment. We'll get into a little bit about that, about making sure that we have appropriate documentation to find gaps in quality. We know that being able to run a business, a community mental health center, community health center in general, you got to be able to be financially relevant. But there's one gap that's often missed, and that goes back to scheduling, which is the gap in the experience. So it's very interesting because I'm about ready to go after this session into another session where here at Innovator we're launching a next generation access center. And there's two aspects to that. And you brought up both of them, which is the outbound. How do you reach out, identify those people with data that you need to reach out that need care, address those gaps in quality and care, or the social determinant gaps. And then the second one is when people want to schedule and they call inbound is what I call that, is oftentimes it's a challenge for them. They're often held up with older access systems, waiting on a phone, finally not finding a time that matches their convenience. Sometimes the appointment may be months away and they need care quickly. And then the journey itself. And I really like what you said about going out and doing street medicine. I certainly used to do that when I ran an adolescent program back in my residency. Used to write scripts at the curbside when people would pull up. And the big question is when you're doing a lot of these activities is, are you able to get some type of documentation, hopefully AI related, where they can scribe that? Because that documentation is, again, so critical to getting the information about the services that are being delivered so that you can actually deal with the financial aspect of getting paid correctly. So a lot of stuff to unpack there. I just tried to pull some of the threads together, which I heard that were very exciting that you're working with.
I am curious, how is the team handling the documentation? Are they using scribing as part of it when they are out doing the street medicine?
Yeah, great question. I would say that scribe adoption is evolving as we speak. We have a couple of very tech-savvy providers, and they caught on to it, and they keep asking us for new capabilities as they hear about them. We also have a lot of providers who just don't trust AI, right? But what we have seen is, I think, our approach to driving adoption of technologies like Scribe has been where we identify a couple of early adopters or pilot users who have then tested it. And our early evidence of the success or not of Scribes has been extremely positive. We use a capability called a bridge. We've used Nuance and DAX. And what we have heard from providers that like it is that it really enables them to focus on the patient and the conversation versus looking at a screen. And also, the entire visit time is also shortened because they're not spending time trying to document while they're also talking to the patient and addressing their concerns. So it's been extremely effective and positive. And yes, depending on the provider that goes for that shelter medicine, we do have scribe usage. And we are actively working on expanding that across the board because we don't have, I don't call it, it's not a push strategy, it's more a pull strategy. So we essentially go there selling or telling the provider about the benefits of it, ask them their current process. We have a number of providers who use medical scribes, offshore medical scribes. We have Dragon dictation. So we have capabilities which are probably not AI, but capabilities that allows providers to not spend too much time doing documentation themselves. But I would say the appetite for AI is continuing to increase and become better. So there's more trust now than I would say even a year ago.
Yeah, that's the wonderful thing about, I think when we say AI these days, we're talking about generative AI, and being able to actually converse and have things recorded from an audio perspective. I know I have the next generation of Alexa at home, and I'm now carrying on conversations with my Alexa, not just asking a question. And it's very interesting, and it seems to be evolving very quickly. The issue of trust, I think that you brought up is an important one. I think there's early adopters, people that feel comfortable right away, and those that are very skeptical. And so you've used a myriad of tools, offshore, human, scribing, listening, and automated. You've listed the top in the industry right now. And I think there's a lot of positives here. We'll get better documentation. Obviously, human needs to be in the loop in terms of reviewing the note, particularly if it's a clinical record. Clinical record is a business record, right, for the healthcare provision. And so you need to have people reviewing those. But I think we're going to capture a lot more than we historically have done by writing or typing. And oh gosh, there's music to my ears, what you just said. My life as a primary care physician, as a physician in general, has been listening to people. And that means eye contact and really understanding them and asking questions and looking for the subtleties in their responses that tell me a lot of information about the truthfulness, the concerns, the wariness. It allows me to explore deeper and do clinical discovery into the calling out the real natures of the symptoms and the social support that they have and what I need to do to help influence their behavior. That's all been lost if I'm typing and looking at a screen while talking to them. I still remember my father before he passed. I asked him about his longstanding primary care doctor, and he says, "Oh, my doctor doesn't listen to me anymore." I said, "What do you mean?" He said, "Well, he's too busy typing on his computer." And I think for many of us, we're finally seeing ways to release that. The good news is better documentation, better data, better identification of care gaps and quality gaps, and more importantly, the better creation of revenue sources for what we have so that we can start doing the types of efforts to be able to maximize our reimbursement for the actual good work that we're doing. So really good topic.
Perfect. And I do want to come back to the technology portion, but we do have a question from our audience. And Malika, do you see a drop in the total cost of care for the patients that the community health workers are interacting with?
It's a good question. So I want to say, for sake of transparency, it's not something that we are actively measuring, but eventually it does reduce the cost of care, because if we are able to address structural needs for that particular patient's or social needs gap and be able to get them to our clinic or wherever else to see their medical provider so they can take care of their preventative care gaps and other things, then yes, over the long run, I think it does translate to lower cost of care and hence better value. So yeah.
Perfect. So going back to the technology, one of the things that, as you're introducing new technologies, how are you getting your staff to be engaged with it while also making sure that you don't have any disparities or ensuring equitable care across your population?
Yeah. So the way we launch new technologies is through really tying it back to our strategic goals and addressing pain points or problems, right? So what we are always looking to understand is if it's a technology that's going to help the provider reduce time that they spend documenting or just doing everything that they need to with the electronic health record, and we use Epic. um, you know, where is it driving value? Are we able to actually truly improve productivity and reduce that administrative burden? I think the second thing is also around improving access, understanding what can we bring to bear that's going to allow patients that need care see us at the right time. And so if that means deploying technology that will quicken the process of the care end to end, what we discovered was, as if we didn't use Scribe, a patient visit would take approximately 45 minutes between everything, rooming and getting them settled and going through it. But with Scribe, I think we calculated it's under 30 minutes or something. So we are freeing up that extra 15 minutes. And so that's real value. And so getting staff engaged is just showing evidence of the value. And I think also, compared to, I would say, 2 years ago than where we are today, a lot of the staff attends conferences. I think AI is no more a buzzword. A lot of them are using large language models, whether it's ChatGPT or Claude or whatever else. So they are getting more and more comfortable, and the trust factor continues to improve and increase. We also get a lot of capabilities introduced to us by our managed care payer as well. We recently, not too long ago, earlier this year, launched an e-consult services because we have a huge gap when it comes to specialty care. We just don't have enough specialists and it takes a long time. So e-consult capability allows us to get a second opinion from a panel of specialists within 72 hours. And so, we are closing care gaps there, improving access, and then sometimes it also results in an incremental visit. So it's all good at the end. Does that help?
It does.
My
follow-up
Malika,
question.
we've been working together in Evasor with your organization as part of the statewide California Population Health Management Initiative with the community health centers across the state, and yours has been right at the forefront of that. Um, you know, part of the way we've thought about things is the importance of the underlying data to really optimize a number of different efforts, quality, care delivery, reimbursement, et cetera, et cetera. And so, and then also population health, of course, which is where we started in our business. How do you move care upstream? How do you begin to do more preventative care, care in the community, and not waiting until people need to be in an emergency room or hospital for a procedure? So how have you thought about the use of data, particularly as it comes to things like risk adjustment, some of these efforts describing where you get better documentation and being able to deliver better coding or quality scores like HEDIS and STARS, etc.
Yeah, great question. So I think data is very fundamental, and I call it the building blocks of how we want to um, look at population health or take care of our patients. And one of the pain points that we have is, yes, we have a fairly robust system of record or electronic health record, but we don't have access to our own data. It sits on the vendor side. So the initiative that we have with PHMI and Innovasa was really to be able to drive interoperability and build a data platform that will allow us to look at our patients and care gaps across the board. And it's been a very interesting experience for us where along the way we faced a number of barriers for data acquisition. And what's really strange is I think healthcare is one of the few industries where entities are very protective about their data. They don't want to share and they see it as a risk. And so fast forward a year and a half, we are at a point where I'm actually now getting into an initiative to build like a data warehouse outside of some of the other initiatives that we have, where we get a replication service of our data that's now sitting on our vendor side. And that will be number one. And then along the way, we are hoping to also add in other data sources, whether it's claims and community health and data coming through our community-based organizations who are key partners, especially when it comes to addressing structural needs gaps in the communities. So I would say we are very much in the early stages of building a robust data infrastructure. And one of my philosophies for my department and for anything that I undertake has been we have to become brilliant at the basics, so then we can add the jazz, right? And so that's my secret mantra as well for my team and for everything that we do. So hopefully that answered your question.
Yeah, it's a really hard world. We have payers and we have providers. And you've been on both sides, I've been on both sides. And there's an issue of trust, right? So, particularly as we move into this idea of AI and using AI to help with coding and adjustment and reporting, where each side thinks they're going to use AI to the disadvantage of the other. So, that's one barrier that I'd like to hear more of your thoughts about. But also, there's the issue that you mentioned, and I really love the way you said it, is we don't have access to our data because it's on the vendor side. Maybe you could expand on that, because this concept of data hoarding or data blocking is such an important issue as we try to get to a better place for all the things we've been talking about so far.
Agreed.
Yeah,
And I'd be
absolutely.
curious about your data governance policies and how you're proceeding with those as well.
Yeah. So answering the first question about our data being with the vendor. So we use Epic hosted by Ocean. And before that, we had NextGen, which was all our data on premise. And so I would say this was part of a transition plan or a migration plan when we switched EHR vendors from going to an on-premise to a cloud model. And the application itself is extremely robust, but when it comes to really getting behind the scenes on the data architecture and understanding more about what we are pulling through the analytics reports, it's really hard and obscure because we don't quite understand the construct. And hence, we decided that we need to build our own data warehouse to get essentially a replication of the data that's now sitting on the vendor side on a daily basis. So that was why we started this project. Michelle, can you repeat your question again? I think
I'm curious about, as you're building all of this out and having moved from vendor to vendor and building your data warehouse, how are you handling your data governance? What are you focusing on for your quality, your accuracy, making sure you've got that completeness, and as you want those daily feeds, making sure that that's going to give the insights you need.
Yeah, so we do have policies for data governance, I want to say, but we are a smaller shop. So most of us wear several hats. I would say we don't necessarily have a data governance committee per se, but depending on our role in that particular project or initiative, I think everyone has accountability to ensure quality, transparency, as well as documentation. Because if we didn't document our findings and how things are constructed, the next person coming in to take on the project doesn't know. And it also allows for that collaboration, whether it's with a vendor or with another entity, right? So at least since I've been at MCHC, I've been a very big proponent across all my teams to have documentation, to have QA processes, as well as also, using data to foster thoughtful and meaningful conversations, whether it's solving problems or things that don't look right, and using that to really achieve solutions collaboratively.
How are you prioritizing these initiatives, balancing the need for the healthcare and the technology to have that data, and also the community needs to making sure that those patients are getting the care that they need and being able to close those gaps?
Yeah. So without having, I'm going to use the term 360 data about our patients. It's really hard to know where there are gaps and who needs them. So I think that's the lens that we use to figure out which project and which initiative is important, which needs to be funded or not. I think the second thing is then not having robust, comprehensive, and good data does not allow us to be very targeted with our interventions. We use what I call a one-size-fits-all model. But if I had the right kind of data and I'm able to build some predictive models and I'm able to stratify my patient population, then at that time I can allocate my resources to those in need, right? High acuity groups and such. Today, that's not entirely possible because we don't have the best data. We have data, it just needs to be improved upon in terms of having more data elements. We don't always know if someone got care outside MCHC. And so there are a lot of gaps. So we need to first try and close those gaps and build a robust infrastructure before we can, implement all the other things, whether it's building, using AI to build predictive models or helping us better stratify our patient population.
Are you seeing any specific challenges right now with those closing of those gaps with, regards to, maybe the preventative screenings? As a result of that data, specifically, is there one area that is the biggest concern that you are trying to address in the next, 3 to 6 months?
I would say interoperability is our biggest issue. So oftentimes, as soon as a patient gets care outside our four walls, that data is either available or it is not. Our electronic health record vendor has done a nice job of improving interoperability, but still it's not comprehensive. So oftentimes we are dealing sometimes with manual paper records of patient's care done somewhere else, right? They might have gotten an MRI or a screening done elsewhere, or sometimes we have to ask the patient. So it is not easy. And so my goal in building a data infrastructure is to also be able to address those interoperability gaps so we can actually have the right kind of data to close care gaps effectively. And what it'll do is it'll improve efficiency, it'll allow us to deliver better outcome and ultimately also reduce cost of care.
And Malika, you've really touched on a really not well understood issue in our healthcare data understanding, which is this concept of interoperability. The term's been tossed around a lot, but it ends up really being a North Star. So different things have come about, like we've digitalized healthcare with the EHR, and then we added HIEs so we can move CCDs around from one point to another. And then we created consortiums to be able to orchestrate that. And we began to bring in labs and other things. And then we came up with APIs, advanced programming interfaces. And now we have TEFCA, which is sort of a framework for how we can create a national health information network. These are just steps along the way to a North Star of having solid, trustworthy data that can be available to those who need it in a private and secure way, of everything in a near or real time, hopefully real time way, of everything within an ecosystem. And patients don't go to just one place, they go to multiple places. And as you've already touched on, there are all these social, environmental, and economic factors that influence the outcomes of care as well. So this is such an important topic that you've talked about, this idea of interoperability, but it's not something that we're going to achieve with any one of these moves, but we continue to make improvements in the way. And an important way, given that what you've described is it's things sit on the vendor side often, is being able to just pull that data in and being able to then work with it and look at providing some governance, ensuring the quality of that data, and then make sense of it. And that's something that we've always done at scale here at Innovacer, with the idea of helping an enterprise leverage all that data and ultimately an ecosystem and being able to leverage it as well.
Dr. Nace, as you work with many of our clients, how are you finding engaging with the providers to get them to feel more confident with the adoption of these technology and interoperability changes that we're working with? What areas do you see concerns in them not wanting to adopt, but what are the areas that are there quickly being adopted and accepted?
That's a great question. And, our view has really been a North Star of that ecosystem view. And I think it really starts with an enterprise, right? Because that's where we are at today. If you work with an enterprise, most healthcare systems are somewhat fragmented, right? They have, I think, as Malika pointed out, they've got an access component, a review, and sometimes department, like a marketing department, that do both outbound and inbound. There's care managers that stratify the risk of patients and help them navigate the healthcare system and the delivery of care, and identifying if care gaps, maybe with care managers, or as Malika pointed out, enhanced care management. And then there's the follow-up when they leave, the pharmacies they go to, the social supports that they get, the transportations that get connected with. So from an enterprise standpoint, we've really worked to look outside that fragmentation and help the health system pull that together, thinking about where the care management department is, the population health department, the specialty side that Malika referred to. How do we think about helping specialists move more upstream? How do we think about the physicians that deliver kidney care to not wait until they get to a dialysis center or have end-stage renal disease, but start identifying that care earlier when their creatinine starts to drift off. And at a primary care, you can begin to intervene along with a renal specialist, but that requires, all these things require data. And also monitoring things in the home. Being able to look at hypertension is not something you come in once or twice a year to be able to have somebody measure it, maybe well or not. Different people measuring your blood pressure, but rather having more Fitbits and Apple Watches, and more people are using these things or delivering it to those who are at risk, so you can monitor it 24/7. So these are the sort of data sets that we look at: access, navigation, care delivery, specialty care, primary care, population health, fee for service, and then most importantly, the revenue cycle. Can't run a business unless you're getting paid. And that revenue cycle is broken in this country, just broken. It's fragmented, it's broken up into pieces, they don't tie together, the data's not all together, it often lies in different databases, and it's not real time. So these are all the things that Innovacer works with, data being the fundamental aspect for that. And so that's the approach we take. And we try, I love what Malika, we try to meet people where they are. You meet an enterprise, a health system where they are. Figuring out, where are you at today? What's the most important thing we can do to add value today? And how do we start on that journey with you to get to to get to that North Star?
Malika, what partnership and support do you feel is most critical for success of programs like yourself?
So it's not one type of partnership, right? So it's many. And so if I start out with the data question and technology question, going back to what I mentioned earlier about, for some reason, I'm not sure why, but in healthcare, though we've had mandates and laws passed to improve interoperability, there's a lot of territoriality when it comes to sharing data. I shouldn't have to pay for my own data access, right? So, and this is the only industry where I'm having to do that. So I think opening up doors and minds for improving interoperability, I think, is a great step. The second thing is, yeah, putting patient in control of their health. And how we do that is through enabling more self-service, allowing them to um, explore devices and capabilities where they're able to keep up with their vitals, whether it's blood pressure, eating healthy, and those kinds of things. And I think going back to preventative care, I think accountability and outreach goes both ways. So while we are actively doing outreach to close gaps, and in some cases we do offer incentives, I think the patient should also feel equally responsible and accountable for managing their health and healthcare. And so there's something there. And I think on the community health side, and when it comes to addressing social needs gaps, we rely on our community-based organizations and network of those organizations to help us close gaps for our patients. In some cases, when it comes to things like enhanced care management, oftentimes we are working with community-based organizations who are also in the same business. So they're fighting for the same patient population for that kind of capability, or in some cases, revenue. But finding the right fit and partners who are invested and have aligned vision and goals, I think, is also important. And then the last thing I would say is just I operate on the side of being very transparent and constantly communicating with my teams, and I call it a co-collaboration model when I'm driving decisions, right? I'm getting inputs from not only my own team, but also from the key stakeholders, because everyone needs to have a skin in the game. And so if you show them what that is, then I think you get buy-in and more alignment along the way. You don't have to fight for it later on.
Yeah, I really like this concept of alignment, and it's one of the great needs in this country for healthcare that we've seen over decades is the need to better align the payer, person that's funding a program, and the provider of services. So, this, as I mentioned, the skepticism, I think it often exists, but there's a great need for collaboration. So think about the areas that payers are very interested in management. They're interested in keeping people that don't need to go to the ER not going to the ER. How do they think about getting people when they leave a hospital or leave an intensive care and get them to the right place, and delivering more preventative care at home? These are key areas to look at where payers and providers can not only share data, but utilize tools that have been traditionally used in population health in a fee-for-service environment, such as identifying people with data, identifying people at risk who are likely to use the emergency department that don't need to, in reaching out and making sure they get the care in the home so they don't need to. That helps the health system identify those people that come into the ED or people they need to get into the hospital to deliver care to. Same thing with getting people, once they need acute care, to the community, is how can we get them to the right place quicker, anticipate that, again, using data, and get them to the lowest level of care. So all of this requires the sharing of good, accurate data between payers and providers, and also the leveraging of tools that have been traditionally used in a population health world in a revenue fee-for-service type driven environment. And I think Malika, you sit in all those worlds. And so I think you're doing the right thing, which is taking the right approach, thinking about data first, developing your database, and really getting data that you can trust to start thinking about these things.
We have a question from the audience, touching on what Dr. Nace had just said. How much of your reimbursement is driven via RAF scores, and have you been able to quantify whether those scores are truly being reflected in a more efficient care downstream?
I want to say, I think we do use those scores, but I want to say we are very much in the what I call the initial phases of being able to leverage the capability at its fullest, only because you need to have good, reliable, solid data, and not having it it puts us at a loss when it comes to leveraging it at its fullest, right? So it's my vision over time to be able to get to a point where we do more targeted interventions, and we are able to look at those risk adjustment scores and then determine what type of intervention a particular patient group or cohort needs, versus what we do today, which is really a one size fits all model. And I don't necessarily believe it's the right approach for the longer term, whether it's for sustainability or also for being able to drive the best outcomes.
With the recent legislative and regulatory changes, what areas are you the most focused on to respond in the next few months? And how are you dealing with these changes as they are ever evolving very quickly for many of us?
Yeah, no, thanks for asking that question. That, in fact, has been top of mind for all of us at MCHC, especially our senior management. Recently we have put together a task force because of the community we are in, as well as our patient population. A lot of our patients are afraid to come for their appointments. And so we have a task force looking at what our response should be and protocol should be if immigration officials come at our doors. We have a lot of messaging, and we are encouraging patients to schedule virtual visits in the case that they don't feel comfortable showing up in person, so they can continue to get the care that they need. I think the ramifications of the big beautiful bill, I want to say, we are still decomposing that, because now the state has to provide an interpretation of what they will or not cover. And myself and a couple of folks in my team are starting to look at data sets that will allow us to predict the impact of whether it's in encounters and patient volume, or also the kind of care that we can provide, right? I also think that there could potentially be some ramifications for our community health services and the kind of care that we can provide, because the bill does not necessarily support non-medical care in its entirety. And so we are starting to look at that. We also have a fair share of sliding scale fee patients. So as you see an uptick in uninsured population, which they will happen because Medicaid eligibility becomes more and more stringent, we are going to see a greater proportion of uninsured population, and hence that's going to have ramifications in the volume of such sliding scale fee and workflows thereof for that.
With the emerging AI trends and technologies, what do you both see as the most promising item that's coming that is going to impact risk adjustment and overall healthcare performance? And how do you look forward to getting engaged with it?
Well, let me take that one first, because, 10 years ago, when we were getting innovators started in healthcare, our primary thought was what's most important is the quality of that data, and also getting, as Malika referred to before, a 360-degree view. And so getting data from different sources, people think there's data standards because we have CPT, ICD, and RxNorm. That's just a small amount of the types of standards. There's no standard for height and weight of a patient. There's no standard for a myriad of things. And so particularly, we look at claims data from payers. We look at data from community sources, community pharmacies, labs. And that doesn't even touch the fact that we start thinking about individual behavior and all these social environmental things. And so we've put lots of effort in how do you normalize and standardize that data? How do you get it into a data model that gives you a 360-degree view, and then prepare that data, enrich it so that you can actually make it available to other applications through advanced programming interfaces, APIs, or even do analytics on it. So we think analytics is so critical to insights. And here's the rub. A lot of people create insights, but they don't get them to the people who need them when they need them. And we call that putting insights into workflow. So if you have somebody in on a finance side that's dealing with, a risk adjustment and dealing with their making sure they've got good data to do their revenue cycle, getting it into their workflow with the tools they use, whatever system they're using. Same with a doctor for an EHR or a pharmacist with their management system, et cetera, or the patient with their smartphone. So that's our perspective here.
Yeah, I think Dr. Nays covered it really well. I think for us, where we are looking at potential AI capabilities would be in the areas of billing and coding. What can we do to improve our coding capabilities, and can it be automated and finessed, right? We have a lot of what I call revenue leakage use cases or aspects depending on the workflow. And so to the extent that we can stop the bleeding and get more accurate with whether it is making sure only most eligible patients getting sliding scale fee, and we are not leaving money on the table when it comes to managing risk and sharing our data with our payers and those kinds of things. So those, I would say, are some of our lower hanging fruits. And once we have a robust data infrastructure established, obviously, we can do a lot more in the way of deploying artificial intelligence to understand data sets and looking at some future behaviors based on our historical data.
Perfect. And as we approach the last 10 minutes of the webinar here, just any questions that folks have for the panelists, please drop that into the chat for them so we can definitely get those presented to them. We want to make sure that you have opportunity to ask anything of our wonderful experts here. As you're looking for the upcoming changes and new AI models, Dr. Nace, what do you see is something that you're excited to be engaged with your team here at Innovaccer as you're working on new offerings for our clients?
Well, for me, I'm a physician, so I'm always interested in improving outcomes of patient care and improving health for population. So what is really exciting is how quickly the technology is moving. This week, this month, it's the use of agentic AI, automated, agentic agents that can do scheduling, that can go out and navigate a referral, that can go out and search for information to bring back. All those things that aren't requiring humans necessarily do a lot of administrative work. That's sort of one area. And the other is be able to discuss with your computer and ask questions. And we call those co-pilots, right? Being able to provide an assistant so people can be looking at their patient or talking to somebody who just called in for trying to get something scheduled or referral managed, and being able to have a third companion as part of that computer that can talk to you and provide information in real time while you're doing it based on the context of the discussion on all that data that you have and provide those insights. So that's the exciting thing, but much more to that in terms of improving health of populations and individual patient care. But that's what gets me excited right now.
And Malika, obviously, as you're working on your new data warehouse, is there anything else that's exciting that you guys are working on that you are looking forward to collaborating either with the Innovaccer team or also just with your team?
No, I think really the data warehouse project is going to be a huge one for us, and trying to then use that as a starting point to allow ourselves to have the appetite for new artificial intelligence capabilities. We have been talking about agentic AI capabilities as well, whether it is for improving productivity on non-clinical tasks in-house or some other areas and use cases. So, and like I have said before, we are trying to get brilliant at basics first before we start to introduce some jazz, and I'm hoping that that won't be too far.
Perfect. And again, If there's any questions, please drop those in the chat. We've got a question here for Dr. Nace. As we continue the adoption of different AI tools and having the human element integrated into the process, which I agree with, however, who is the best qualified human element to be able to review the clinical record as an example?
I think in reviewing the clinical record, it should be a licensed clinician who's in charge of or responsible, one of several often, in the care of the patient, or more importantly, those that are looking at broader cohorts of patients, like for a population, a specific initiative. But in terms of reviewing the record, I think AI can really do a lot of work with helping to make that such more of an efficient process by flagging, bringing forth areas of issues for someone to take a look at and make a decision. But right now in clinical care, there's a training and human element that needs to be brought as a companion to the computer work to really help make good decisions.
And as somebody who's doing coding platforms, I am very excited for the future and what we're bringing to that very much. So again, thank you both for the time today, and thank you for our attendees that have joined us. I appreciate both of your time, and you should be seeing a survey form popping up for those of you who are still attending. We greatly appreciate your attendance today and look forward to you joining us in future sessions.
Thank you.
Thank you.